My presentation is very promising and attractive topics. Transoral thyroidectomy, a novel endoscopic surgery in Bangladesh. And this is the scar after conventional surgery. And see the picture of the neck after endoscopic thyroid surgery. First transoral endoscopic thyroid surgery done in vestibular approach in 2014. Commonly used remote access thyroidectomy, axillary, bilateral based approach, facelift, and vestibular approach. Comparison of the remote access thyroidectomy, invasiveness less in transoral thyroidectomy, manipulability of instrument less in transoral, operative time more or less same, quality of surgical view excellent in transoral thyroidectomy, applicability of central and central and total thyroidectomy possible in transoral thyroidectomy, lateral neck dissection it is difficult through the transoral approach, cosmesis is better, complication more or less same. Transoral approach, it was first started with sublingual approach, then vestibular, submental and combined approach. And this is the site of port, midline 10 mm port for camera, two lateral 5 mm port just lateral to the canine teeth to avoid the injury of the mental nerve. Transoral thyroidectomy, robotic, endoscopic, carbon dioxide insuppression method and gasless method. And I think this is the most important slide. Patient selection, benign nodule less than 4 to 5 cm, low risk differentiated thyroid cancer less than 3 cm, less than 10 cm and less than 45 ml volume on ultrasound, female, right lobe, isthmus tumor, no big goiter, no severe thyroiditis, not located at the uppermost part of the superior lobe, not too short, not too long neck, not too fat, not too thin neck, not too small mouth, no prognathic mandible. And now I am discussing about the procedure and technique. This is the marking on the skin. Position of the patient, it is usually done in the nasotracheal intubation with neck slightly extend. Painting with the betadine and normal saline mouthwash. This is the marking point. Thus I am showing the insertion of the port. This operation done on the Shohid Sohrawardy Medical College Hospital 2 days before. Our respected Professor Matin sir, Professor Sajan Kabir sir and Dr. Saifuddin sir was there. I am trying to meeting the central port for insertion of camera, 10 mm 30-degree camera. This is the Veress needle. I put the normal saline mixed with adrenaline, 30 ml into the neck to elevate the flap from ischial muscle and from platysma. This is the 10 mm port for laparoscopic camera. Be careful to avoid the skin of the neck. Yes, finally we have done. Now it's time to lateral port, just lateral to the canine teeth to avoid injury of the mental nerve. So the port on the other side. Sir? Yes, this is the 3 port we have already done. So the another video. This is the video after insertion of the port. We are trying to elevate the flap. From the submental to the supraesternal notch and laterally from the between two sternocleidomastoid. Now this is the separation of the step muscle from the linea cervicalis. Okay. Just now we are trying to identify the parathyroid gland and recallaryngeal nerve. After identifying the recallaryngeal nerve and parathyroid gland, we remove the tumor. Okay, but try to go. Yes, follow up some patient. This is the picture after 1 month of my operation. And this is after the 15 days only. And see the after 15 days. This is the site of injury of unipolar. Okay, sir. Follow up of the some patient. And this is the picture after 3 months. See the lip and neck. And then complication. Recallaryngeal nerve injury, hypoparathyroidism, hematoma, seromental nerve injury, surgical site infection, carbon dioxide embolism, skin ecchymosis, bruising, skin burn, piercing of the by needle, skin flap perforation, and skin complication this type, and tracheal injury by the power instrument or Heger dilator, and most grave complication I think this is conversion of the procedure. We have to change the aim of the surgery. Uncontrolled bleeding, especially from the superior thyroid artery, inability to remove the tumor, especially from uppermost part of superior pole, carbon dioxide embolism, tracheal injury. Track recurrence, another complication. And significant advantage of the transoral thyroidectomy, nasal orifice surgery, no skin scar, better preservation of the postoperative voice, can perform lobectomy or total thyroidectomy or neck dissection, shorter length, no instrumental collision, easy to perform, excellent anatomical view. And summary, transoral thyroidectomy or endoscopic thyroidectomy is feasible and comparable to conventional thyroidectomy. Transoral approach might be preferable to the other remote access thyroidectomy. There are unusual complications such as carbon dioxide embolism, mental nerve injuries, surgical site infection, skin flap perforation, skin burn, and trauma. The essential advantage of transoral thyroidectomy are superior cosmesis and voice outcome, strict patient selection criteria, and overcoming the learning curve are important. Robotic thyroid surgery will no doubt progress as robotic technology evolves. With my professor Okay. Last but not least, if you can dream it, you can do it. Yes. Thank you all.
Hello. Thank you, Dr. Mahbub. Now I request Professor Matin sir to deliver his lecture.
Before that, actually, congratulations, Dr. Mahbub. It's a good initiative. And I was the part of the history because it was done first case at Sohit Medical College Hospital, I think 4 months ago.
Yes, sir.
And we had a good media coverage. And we are there and just a courageous man, we must give congratulations to him because it's a new invention. It's not invention, but innovation. Because as you know, as he said, dream. If you want to do, you have to just dream it, otherwise you cannot. So thank you very much. This is the second case, but he has already done, I think, how many did he do? Baruta. 12 cases he did outside. So I think, like endoscopic sinus surgery, one day somebody will do that. Like your copulation. I started before, but now most of you are doing copulation nowadays. I don't know. What do you think? Okay, so yes, cancer, yeah, recent. So actually, I would like to, because I know you are. Yes. So I know you are very hungry. So I'll take few minutes to give a good, a little talk about thyroid carcinoma management. Because, sorry, that I'm saying, because I'm now in Ireland, I like to give this. This is actually there is some theme behind that. Thank you, sir. My dear chairperson and my audience, my respected teachers, Abdullah sir, and my senior colleagues, Kamal sir, Fitul Mazumdar sir, Hassan sir, and all of the other, Litu and Aisif Fakir and Shajan, and yes. So basically, my topic is current trends in the management of thyroid cancer. We know about that. We know what is new actually. New is I'm coming up that this is my hospital where I'm working. Now I'm just doing head and neck surgery at Limerick University Hospital. It is the third largest city in Ireland. We know the classification, but we are talking is differential thyroid carcinoma. As you know, it is out of 100 cases, about 85 to 90% is differential thyroid carcinoma, and the papillary carcinoma is mostly 85 to 90% is papillary carcinoma. Others very little is follicular other carcinoma. So the incidence, as you know, the incidence of thyroid cancer is increasing nowadays all over the world. Even my 3 or 4 studies in Bangladesh also it showed lots of incidence of thyroid cancer. But is it the real incidence? Why the incidence is increasing? We saw that lots of investigation we are doing. Like we are doing lots of ultrasonogram in every street. We are doing ultrasonogram, we are doing FNSC, so that may contribute the real incidence of thyroid cancer. That is the reason that's saying that yes. So we can say the rising incidence of thyroid cancer is primarily epidemic of diagnosis rather than true incidence. Even the incidence is increasing, but the mortality rate of thyroid cancer is not that much increased. Only 0.4 to 0.5%. So that means only 0.1% of increased mortality in thyroid cancer over the last 25 or 30 years. So then why it's what I would like to remember one patient or one case is Khushid Bhai, Jatin Shah was delivering the lecture about thyroid cancer, and he said, who told that thyroid cancer need any surgical treatment? Who told you? So I was really surprised why he's saying that. So that is the question nowadays, that recent advances in thyroid cancer management. What is the main challenge? The main challenge is they are balance, to seek a balance between the risk and benefit. Are we doing overharm to the patients? Are we doing excessive surgery or not? So that is the question. We are doing the under treatment of high risk patients or over treatment of low risk patients. That is the question. Very crucial question. Over treatment of low risk patients or under treatment of high risk patients. So we have to seek the balance. That is very important. Does all DTPC, that means differential thyroid cancer, need surgical treatment? I would like to ask this question to the gallery. Do you like to do all patient surgery? Sir? So you agree that you will do surgery for all patients? In Bangladesh perspective, okay. Yes, sir? No. Yes, of course no. So management of thyroid cancer now is de-escalated, de-intensifying, rather than going for aggressive surgery. We are very much conservative nowadays. Very much conservative in treatment and management of thyroid cancer. So now, so this is a de-escalation or de-intensify mammon. We're not aggressive. Just go and do the operation. You know, put your scissor on the patient. No. Now this is coming up, the observation and the observation. And that is the question of surveillance. Because when I started my head neck job there, with thyroid all patients, put on surveillance. I know, my God, what is surveillance? What is surveillance? I am in from Bangladesh. Any patients coming from thyroid, I just either do operation. What is surveillance? So for that thyroid patients, if it is benign, they never do operation. They go surveillance, regular follow-up with ultrasonogram, and say the size of the tumor, is there any new change coming up, like macrofacial calcification or not, or increasing size. Otherwise, they'll go for surveillance. And eventually, many of the patients stop growing, rather reduce the size. It was 6 centimeter or 4 centimeter. After 6 months, 4 centimeter, 2 centimeter, 3 centimeter. So it's happening. That's why this question of surveillance. Is it applicable in cancer, sir? Yes, it's also applicable in cancer. So that is the question now, surveillance. So there is a lot of patients now go for surveillance. That means, yeah, active surveillance. Yeah, of course. So it's a follow-up. Now, and there is data actually. Look at this. They found low rates of tumor growth over time. That means 3 millimeter or less among 6.4% only over 5 years and 10% over 10 years. So that is the question, that is so slow growing cancer of thyroid papillary carcinoma. So why you should go for surgery? There is one big study about 115 patients. So that is the question of surveillance, and they showed the data that even though the cancer 4% or less, not go for aggressive surgery, rather than go for lobectomy. And they show the data that the overall survival benefit is equally. So my dear colleagues, even you can practice this only in Bangladesh. Also we'll have less money. We'll have less car or good, I mean, not BMW, but at least we can survive. We can give the benefit of the patient. So the active surveillance is also applicable in Asia, because as you know, the largest data is in Kuma Hospital, as you know, in Kobe. We went to Kobe like one time on the conference. So that is one, and they showed the 22-year study about 2,153 patients, and they showed this is applicable. It's applicable in Asia, so why not in Bangladesh? So active surveillance in older patients as well, because if you do operation older patients, lots of comorbidities, complications. So why you should go for that? We can go for surveillance. And this is a MSKCC data, as you know, in surveillance. So we go for surveillance. It's safe, effective surveillance. Look at this also, patients of T1, even they say that even 1.5 centimeter thyroid nodule, you can safely go for surveillance. No problem. Yeah, I know. But still, now listen, we're talking about UK, Ireland, and USA. They are also going for surveillance. They are also going for surveillance. But you have to give up the patient's choice as well. You have to discuss with the patient what the patient needs, what the patient asks. If no, this is cancer inside me. No way. Definitely have to go for operation. So you have to also ask the patient that we have the data, this one, with survival benefit equally effective, so you can, this choice is in your hands. The goal is, our ball is in our court. So okay, go for surveillance. Now, contraindication, definitely, in a high-risk patient will not go for surveillance. The patients with high-risk patients, metastasis to lymph nodes, trachea, all invasion, definitely do not go for surveillance. So transition from active surveillance to surgery, when? If the tumor is growing, that will say that 3 millimeter growing, about 6 months, something like that, then definitely you have stopped surveillance and go for operation. That's it, a very simple case. Now there's another important point in favor of surveillance, that we are now downstaging the tumor by 30%. That means when the tumor was stage 4 disease, now they say stage 2. Right? This is the Joint Commission, report, as well as the new recent journal. They said that they already downstaged the tumor. So that is good for surveillance. Okay. So the current treatment options, active surveillance, that should be practiced in our country, in Bangladesh as well. Kamal sir, what do you think? Yes. Now limited surgery, will not, even for the 4 centimeter or less tumor, not go for total, go for lobectomy. And of course, you have to go for total thyroidectomy with neck dissection if it is high risk patient. And then next step is, with that, radioiodine ablation. Does all the patients need radioiodine ablation? Definitely in the high risk patient. Not for the total thyroidectomy, low risk patient, no, don't go for ablation. Only for the high risk patient. Now, there are some cases when the ablation fails, then what to do? That is the question. In our country, no treatment. After that, we only just look at the patient and patient will die. But in advanced world, all over, even in India, I think they have already started this targeted therapy. So, radioiodine therapy in DTC, as you know, this is the classical treatment of high-risk patients. After total thyroidectomy, you go for radioiodine ablation. And even the high-risk patient, the mortality rate, 10-year survival rate is high. But if the patient has got recurrence, or sometimes the radioiodine therapy doesn't work. There is one molecular level that why the radioiodine ablation is not working. About 30% patients not responding to radioiodine ablation, and that is called refractory thyroid cancer. Every day, I mean, why is that? They said that is NIS. It's called actually the sodium iodide symporter, and that is responsible for taking the iodine actively to the thyroid cells and cancer cells. So there is some patients with the deficient of this one or inactive. So in this group of patients, the radioiodine is not active or works. So in this group of patients, now the new drug is coming up to modify this NIS, and then for that group of patients, there's a question of targeted therapy coming up. So radioiodine refractory cases, as you know, 10% of patients with thyroid cancer develop advanced disease, which could become resistant to radioiodine ablation. In this case, the 5-year survival rate can be low as 10% in comparison to 56% in metastatic carcinoma, where the radioiodine is active. So the survival benefits are going down from 56% to 10%. So treatment, what is the treatment then for RAI refractory thyroid cancer? The question is, they also, why is that there is some oncogen, as you know, RAS, BRAF, and RET. So there is a study, phase 2 study going on to assess some other drugs which can give, activate the NIS system, and then the radioiodine ablation then works. And this is the drug actually, the new is called tyrosine kinase inhibitor drug, sorafenib and lenvatinib. These are drugs is available now in all over the world. I don't know in Bangladesh, sir. Kamal sir, is it available? Yes. No, but is it available, sir, here in Bangladesh, these drugs? Available, eh? Okay, so these are drugs now they are giving. Okay, so sorafenib and lenvatinib is tyrosine kinase inhibitors drugs. Actually, what they do actually, the tyrosine kinase, you know, this is the protein actually who give lots of positive impulse to grow the cell. So they stop this one with this. This is sorafenib and lenvatinib is the drug for these resistant cases. There is actually one is PDLI. You know, there is a cellular label. This is hydroxy A4, and PDL1 means, what is PDL1? This is actually the ligand. This is the death actually. The one of the death ligand one. That means there is one of the oncogen or protein who is kill the cells, always kill the cells or give amplification to this. So that is PDL1 is another co-proteins. And now the new drug is coming up to deactivate the PDL1. PDL1 is a notorious protein actually for the cancer cell growing. So now these the new drugs are I was in head neck cancer workshop in Ireland. So one of the chap came from America. So he was talking about pembrolizumab. This is a new drug. Going on for this is a phase study going on, phase B study I think, for these new drugs for the refractory thyroid cancer. That means when the cancer is growing so fast with high recurrence rate, giving all over the other, there's no treatment. And the last treatment they are trying with this pembrolizumab. This is a drug, actually PD-L1 inhibitor, and now this is on trial. So that is our treatment goal is that. That means we don't want any death, we don't want any recurrence, we don't want any complication. So that is my key point. So what did you learn then from this today's discussion? That in thyroid cancer, mostly papillary carcinoma thyroid, mostly they are benign because they are slow growing, indolent growing, behavior is very silent behavior. So why should we go for surgery? If we can go for active surveillance, we can save patients money. We cannot save our pocket, but we can save patients money, complication less. So we can go for surveillance. Of course, you have to follow-up system. Because our patients also have to see that these are the illiterate patients. They don't come to us. So definitely you need to follow up. Serial follow-up with the ultrasonogram, all this. So active surveillance, and we will go for limited surgery rather than aggressive. And if you go aggressive surgery, then you go for treatment ablation. And if the ablation doesn't work, then go for target therapy. But I don't know target therapy, when it will come up. Thank you very much. Yes, Lito. Yes.
Thank you, Modin sir, for your very nice presentation.
So this is the front view of the hospital, Limerick University Hospital, where I am working now. Thank you. My house. No. Okay, thank you. No, that's very good.
মামুন আমি এক মিনিট সময় নিছিলাম এটা হচ্ছে
Take your
স্যার
time.
যে মডার্নিটি অলওয়েজ ডাজন্ট গিভ দ্য বেস্ট রেজাল্টস
Yes.
আমি একটা থাইরয়েড কার্সিনোমার পেশেন্ট সে পেপিলারি কার্সিনোমা ইট ইজ এ ভেরি স্লো গ্রোয়িং টিউমার ভেরি স্লো গ্রোয়িং 1 গ্রাম ওজন হইতে সময় লাগে 10 ইয়ার্স সো অন দ্যাট মেরিট উই ক্যানট কিপ এ very toxic snake in our backyard that they will grow later and they will bite us. This is my own.
Yes.
I am not contradicting your any point.
Yes.
But with my humble submission, I like to say, where there is a malignancy, I myself like to cut it out.
Yes.
As a principle of surgery,
Yes.
Is there any malignancy? You should remove last available cell. If you cannot remove the last available cell, you should not do the surgery.
Thank you, friend.
Sir, আমি শেষ করি. And observation, other things,
Surveillance.
radioiodine, observation means surveillance one sort of. Whatever you do, যে কোনো ফ্যান্সি নামে আমরা ডাকি না কেন, for a social, cultural, economic perspective on our population, this 18 crore population, I will never go for surveillance, myself at least. I will go for the traditional treatment. I will just do the surgery and keep him in observation, and if necessary, advice for radioiodine ablation.
Okay,
sir.
thank you.
Thank you, Dr. Litu, for his opinion. Actually, every case should be considered individually. And Dr. Dewan Hassan sir has said active surveillance. If active surveillance is possible, then we can wait. If a person is 80-year-old, very small tumor with cardiac patient, and it's very slowly growing, I personally will not go for surgery. And so every patient should be considered on its own merit.
Yes.
I think everybody is hungry. Dr. Mamun,
So
organizers.
patient for papillary carcinoma when go to Babur Bhai should be referred to Litu Bhai for doing the surgery.
Yes.
So thank you very much. So this is the lunch time, and I like to call.
এটা হলো অটোপসি স্পেসিমেনে যখন আমরা অটোপসি করি তখন কিন্তু 9 to 10% কেসে কিন্তু কার্সিনোমা পাওয়া যায় থাইরয়েডে সো
কিন্তু
ইন লং টাইম
লিটু
যদি
ভাই,
80 ইয়ার্স হিসাব করো তার তো আসলে এমনি কিছু হবে না।
Thank you very much.
না,
So
এটা না-
we are
Mamun,
giving the memento
Mamun,
in informal way.
না আমরা যারা এক্ষেত্রে সাইকিয়াট্রিক্যাল যেটা গ্রাউন্ড আছে সেটা হলে গিয়ে যখন ওয়ান্স একবার এটা কার্সিনোমা ডায়াগনোসিস হয়ে যায় পেশেন্টের যে ফোবিয়া আছে তাদের ঘুম হারাম হয়ে যায় এটা কিভাবে রিমেডি করব আর সবচেয়ে সময়ের হলে গিয়ে বাক্যের নির্মম পরিহাস যে হলে গিয়ে বাংলাদেশের সবচেয়ে হাই ভলিউম থাইরয়েড সার্জন এখন সার্ভেইলেন্সে যাচ্ছে
ঠিক আছে সার্ভিলেন্স এখন
একদম ভালো কথা বলছো।
মতিন স্যারের চেম্বারের বাইরে বসে থাকতে হবে যাতে থাইরয়েডগুলি নিয়ে নিজের চেম্বারে ঢুকে কেটে ফেলতে হবে। ওকে, থ্যাংক ইউ ভেরি মাচ ফর নাইট ডিসকাশন। This is the lunch time. After the lunch, we will return back to the auditorium. There will be a surgery, live surgery, that will be operated by Dr. Hanif. আমরা ছোট হানিফ যাকে বলি, জুনিয়র হানিফ. Now he has become